Hi everyone, my name is Carrie Matthews, and the article I chose was Exercise Treatment for Depression, Efficacy and Dose Response by Dunn et al. So the study mentioned two specific goals at the beginning. First of all, they wanted to know whether exercise is an efficacious treatment for mild to moderate major depressive disorder, or MDD. And then they wanted to know what the dose-response relationship was of exercise and reducing those depressive symptoms. So basically, does it work, and if so, in what dose, and so on. So the reasons for the study is that MDD ranks second for years of life lost, according to the Global Burden of Disease study. And what the researchers pointed out was that only 23% of MDD sufferers actually seek help, and only 10% of them actually get adequate help. So there is a large majority of sufferers of major depressive disorder who aren't getting the help they need. And one really important factor of this is that depression and getting mental help comes with a lot of stigma from friends, families, coworkers, and so on. But exercise does not have a stigma because it can be a therapy for anybody, and it is recommended for anybody, and it's part of a healthy lifestyle. So if it can do double duty as also a treatment for mental health disorders, then that's an incredibly large bonus. So the study design, it was done between July of 98 and October of 2001 at the Cooper Institute and the University of Texas in Dallas. It was a single-blind, randomized 2x2 factorial study plus placebo control. So basically what that meant was there was the placebo group, and then there were 4 other groups. There was the aerobic exercise in either 7 or 17.5 kcals per kilogram per week. And then there were either 3 times a week or 5 times a week. And so if you think of it kind of like a grid, there was 2 different columns and 2 different rows, making up those 4 groups plus the placebo. And then we refer to them as the PhD 3 and 5 and the LD 3 and 5, and then the control. All exercise was supervised in the laboratory by research assistants. The research assistants who then later on tested them for their mental health surveys were different and were blinded to what interventions they actually received. So the measure that they used was the 17-item Hamilton Rating Scale for Depression, the HRSD-17, and that's basically a survey that the participants filled out weekly with those blinded research assistants. So the participants, they started out with like 1,600 participants, and they used extremely rigorous exclusion factors to whittle it down to 80 participants, 72 of whom started and 53 of whom completed. They were aged 20 to 45. They were co-ed. About 75% were women. They were all diagnosed with mild or moderate MDD, and those scores in the parentheses there, 12 to 16 and 17 to 25, were their HRSD-17 scores, which we'll talk about a little bit later. So each of these people had previously had a sedentary life of less than 20 minutes 3 times a week of exercise. They were not receiving any other treatment for depression, and they lived close in proximity to the lab. People were excluded from the study for a whole list of things such as suicide attempts, risk of suicide, psychiatric hospitalization, excessive alcohol use, excessive weight for their height, and so on. So the methods that were used, they initially did several surveys, 1 on the phone and 3 in person, to analyze mental status and other eligibility criteria. Then everyone who was chosen did a 2-week run-in period to assure that they'd be able to adhere to the program and that they had abilities to do it. And that run-in period was light exercises 6 times 15 minutes. So it wasn't the actual program they were going to do, but just kind of making sure they'd make the appointments. Then the actual intervention time was a 12-week program. It was randomized into those 5 groups, like I mentioned before. The control group was 3 times a week, 15 to 20 minutes of stretching flexibility exercises, and then the other groups were either those 3 times a week or 5 times a week on treadmill or stationary bikes. So the measures that they used in the analysis, like I mentioned, the research assistants who did the survey with them afterwards were blinded to what treatment they had had, and then they were looking for 3 different outcomes. Their primary outcome was any change in HRSD 17 results. Then their secondary measures were the response and remission. So the response, contrary to what we might think, the response that they're mentioning here is a 50% reduction in symptoms. And then remission is an HRSD 17 of less than 7. The data was analyzed in 2002 and 2003. They used an analysis of covariance, with the HRSD scores, and logistic regressions for response and remission rates. They did adjust for age, gender, baseline HRSD, run-in period, BMI changes, dropouts, adherence, and so on. And they also did take quite a bit of demographic information such as marital status, ethnicity, and so on. So what were the results? The primary results, which were, like I said, the change in the HRSD 17, were broken down into 2 different groups. There's the intent to treat group, which was that initial 80 participants. Then there was the efficacy analysis, which were the people that actually started the program. Not the people that completed all the way to the end, but the ones who started at least one session. So in the intent to treat analysis, there was a mean reduction of 30% in the HRSD score. The lowest score was in the PhD 3 group, which is that high intensity group 3 times a week. The highest score, which was the worst, was in the placebo group. Then with the efficacy analysis, they found that there was a decreasing linear trend in the HRSD scores in all groups. So basically what that was showing was that everybody was getting some sort of an effect, but some groups were getting more effect than others. And the PhD, so the high intensity groups, were significantly more effective than the low intensity group. The low intensity group was not statistically different than the control group. The 3 times a week was not statistically different from the 5 times a week. And then they didn't find any statistical significance to energy expenditure and frequency, and age and gender. So the secondary results are the response and remission. And they found that 24 out of the 80 participants responded to the intervention. So they had 50% reduction in symptoms, and they had a mean HRSD score of 5.9. The greatest response rate was in the high intensity 5 times a week. The second thing they found was that 20 out of the 80 achieved remission, which meant that their score was less than 7, and the mean of those scores was 5. The greatest remission rate was in the high intensity 3 times a week. So the cool thing, though, is that they showed increasing trends towards probability of response in both the high intensity and low intensity, but not in the control group. So that's kind of a mouthful, but basically what it means is that everybody was headed in the right direction. So both the high intensity and the low intensity probably would have gotten to that 50% response rate given more time. But the low intensity were just going a little bit slower. And what is pretty cool here is also how they describe the statistical significance for eliciting response and or remission. So when talking about response and remission, the high intensity was not significantly greater than the low intensity. The low intensity was not significantly greater than the control group, but the high intensity was statistically significantly greater than the control group. So that's kind of confusing, but basically the differences between the groups were small, but when you looked at the total difference between the high intensity and the control group, it was significant. The 3 times a week and 5 times a week were not significantly different in a statistical sense. So other considerations to take into account was their adherence rate. The control group only had a 42% adherence rate. However, this is because they mentioned in there that quite a few people found out they were going to be in the control group and basically just doing 15 minutes of stretching, and they basically said, well, I'm out, before they even started. So there was quite a high dropout rate. And because the sample size was so small, that equates to quite high percentages when you look at it statistically. So here you can see also, as far as adherence, they had the best adherence with the frequency of 3 times a week, and they had pretty equal adherence between the high intensity and low intensity groups. The dropout rates you can see there as well, and then they had a couple of adverse events like chest pain and joint swelling. But super interesting to look at these different numbers as well. So what were some of the limitations of the study? Obviously, it was a small sample size. As I mentioned, it was also performed in a social setting in the laboratory, which might have been a possible confounding factor. Then, like I mentioned, they were in a lab, so they were really focusing on internal validity, making sure that they quantified the exercise expenditures and so on. But that threatened the external validity of, what's it like in the real world, basically, for people. Are they going to be alone? Are they going to be with friends? That might change the outcomes there. So basically, you had to take into account, if you're going to do it in the lab setting, then it might not be as valid in the real world. They also were not able to doubly blind it, so they weren't able to blind the participant to their own treatment. So this also led, like I said, to some dropouts from the placebo group right at the beginning. So a little bit of discussion, some of the main conclusions they came to. The overall best result was in the high intensity group, but both the high intensity and the low intensity had results, and adherence is super, super important. This, I think, is really important to find what works for the participant, what works for our clients. And like I mentioned, they had a much better adherence rate with the 3 times a week, it seemed like. So that might be a solution for, especially for special populations, such as people suffering from depression and possibly lack of self-efficacy. Maybe we just basically have to find what works for our clients and for our patients. So also the remission rates were similar to other treatments such as cognitive behavioral therapy and antidepressants. You can see those percentages there. And the low dose and the placebo of this study were comparable to the placebo groups in other studies with antidepressants. The adherence rates, even though they were a little bit wonky, they were actually similar to medication trials for depressed patients. So again, we got to think about the population that we're working with. And the key that they found seems to be the total energy expenditure, regardless of how many days, whether the 3 days or 5 days, but really just having that massive energy expenditure seemed to be the main contributing factor to those better scores. And in summary, aerobic exercise in the public health recommended dose can be as effective for depression as cognitive behavioral therapy and antidepressants for mild and moderate MDD. So what are my final thoughts? I think this study was one of my favorite studies to read, actually. It was incredibly detailed and clear, straightforward, super well thought out, easy to read. There were great charts and graphics to just make it clear and concise, and they also included a lot of detail so that the reader is able to make conclusions for themselves, make calculations for themselves. They explained the methods really well, very detailed. They took into account a lot of compounding variables, so it would be easy to reproduce this as well. There was a really good analysis as well that took into a lot of factors. It would have been cool to see more of the demographics and so on, which I think would come out with a bigger study to kind of dive into those factors a little bit more. And that leads me to the next thing. It was a small sample size, and there were a lot of adherence problems, which, like I mentioned, throws off the percentages. So we've really got to find, when we do studies like this, we've got to find what is realistic for the people. what's going to work, and hopefully get a larger sample size, because I think that this would also help studies like this to stand in the face of big pharma. I'm not knocking any pharmaceuticals here, but if exercise can be as effective as a pharmaceutical without the side effects and without the stigma, then I think that there should be funding for really larger scale studies so that they can stand on their own alongside the heavily funded studies that are out there. Yes, like I said, it would be super interesting to see a larger study with this, and I think it would be very beneficial because it has extremely important clinical implications. And here's my reference. I hope that you guys learned something new from all this, and thank you very much.